Uh, Good afternoon. I'm presenting a case of hemangiopericytoma in external auditory canal, a rare clinical presentation. Hemangiopericytoma are rare vascular tumor originating from pericytes, which are contractile cells found around capillaries and venules. First described by the Stout and Murray in 1942, hemangiopericytomas are characterized by their property to occur in a wide range of anatomical sites, with the most common location being the lower extremities and pelvis and retroperitoneum. However, their occurrence in head and neck region is relatively uncommon, accounting the approximately 15% of all cases, even fewer reported in external auditory canal. So, the presentation of hemangiopericytoma in external auditory canal is exceeding rare and with only a handful of cases documented in the literature. The tumor is known their unpredictable clinical behavior ranging from indolent growth to aggressive local invasion and distant metastasis. The rarity of hemangiopericytoma in external auditory canal possesses significant challenges in diagnosis and management, often leading to delay in appropriate treatment. The diagnosis of hemangiopericytomas relies heavily on histological examination, where the characteristic is patternless pattern of spindle cell and numerous thin-walled branching vessels known as staghorn vessels are observed. Immunohistochemical staining also critical with hemangiopericytomas, typically showing positively in markers such as CD34, Vimentin, CD19 and BCL2, and negative for S100, with the differentiate it from the other spindle cell tumors. Given the potential to local aggressiveness and recurrence, complete surgical excision with a negative margins remains the for the treatment of hemangiopericytoma. Adjuvant radiotherapy is often employed in these cases with a higher risk of recurrence or when complete resection is not feasible. So, here is the case of 71-year-old male presented in the otorhinolaryngology clinic with the 6-month history of painless progressively enlarging mass in his left EAC. The patient also reported associated tinnitus, progressive hearing loss in the affected ear. His medical history was significant for occasional ear discharge from the left ear since childhood, but no other relevant systemic otologic conditions were noted. Upon physical examination, the mobile reddish soft tissue mass was observed in the concha of left auricle. The examination did not reveal any cranial nerve involvement. The left EAC examination was also notable. It is given in this picture. We have done the contrast enhanced computer tomography scan. The temporal bone was performed, which revealed the heterogeneously enhancing soft tissue mass within the left EAC. The mass was causing erosion of adjacent structure, including the left tympanic membrane and the crus of Ellis. Additional findings included the soft tissue opacification within the middle ear, mastoid sclerosis, loss of mastoid air cells, limatization. These imaging findings were suggested locally aggressive progress, which is shown in the figure. Then biopsy was taken and histopathological examination revealed the diagnosis of hemangiopericytoma characterized by the spindle cells. And also we have done the immunohistochemistry, confirmed the diagnosis of positive staining for CD34, Vimentin and CD99 and BCL2 and negative for S100. So, given patient's age, symptomatology and desire for definitive treatment, surgical excision was pursued. The tumor was excised entirely, measuring approximately 2 cm into 2.5 cm. Post-operative histopathological analysis confirmed the diagnosis of hemangiopericytoma. Following the surgery, the patient underwent adjuvant radiotherapy to minimize the risk of recurrence. The patient was closely followed for 2 years post-operatively, when he showed no signs of recurrence and experience of significant improvement in hearing and resolution of tinnitus. No further complications were observed. So, in the discussion, the hemangiopericytoma is rare vascular tumors originating from Zimmermann's pericyte, which are contractile cells located around capillaries and venules. These tumors can arise through the body, most commonly in the musculoskeletal system and less frequently in the head and neck region. Occurrence of hemangiopericytoma in external auditory canal is infrequent, with only a few cases reported in the literature. So, the patients presented with the hemangiopericytoma in external auditory canal is challenging due to their non-specific clinical presentation. Patients typically present with the symptoms such as painless mass, hearing loss, and sometimes tinnitus, as seen in our patient. In the symptoms overlap with the other common EAC lesions like ceruminous gland tumors, squamous cell carcinomas, and other cholesteatomas. So it is mostly confirmed by the histological examination with the patternless pattern of spindle cells, and also by the immunohistochemically hemangiopericytoma is diagnosed. In the conclusion, the cases of hemangiopericytoma in the EAC undergoes the importance of considering rare tumors in the differential diagnosis of atypical masses in the ear. Despite of rarity, the hemangiopericytoma can present with a non-specific symptom that mimics more common ear pathologies, making accurate diagnosis essential for appropriate management. The successful treatment of this patient through complete surgical excision followed by radiotherapy coupled with the vigilant follow-up results a favorable outcome with no recurrence observed over 2 years. This case highlights the value of a multidisciplinary approach in managing the rare and potentially aggressive tumor, emphasizing the need for early detection and comprehensive treatment to achieve the optimal patient outcome. These are the references for the case. Thank you.
Thank you. Now I request Dr. Sambhaji Chintale sir to felicitate Dr. Vaibhavi Patil.